Charles Levy, thank you for joining us today.
You're very welcome. It's good to be here.
So, Charles, you have a white paper that is coming out by the time people see this video. It will be out, titled "The Storm is Already Here." And we're going to talk about that title in just a moment, but it focuses on workplace violence and healthcare. Most people who study workplace violence come at it from inside of healthcare, clinicians, administrators, safety officers. You come at this from the perspective of sociology. You're a sociology professor. Tell us a little bit about who you are and how you ended up applying your craft to this particular topic.
I've been a sociologist for over 30 years, and one of my areas is organizational sociology. It's the study of human interaction. It's the study of people within a social context. Um, Part of sociology is groups, and organizations are just simply large groups. And so a subject like this that affects so many people and that's so important in society today could really benefit from a sociological viewpoint.
Charles, you told me previously that your mother was a nurse. How did the fact that your mother was a nurse shape how you see this issue now?
When I was a child, my mom went back to school to become a nurse, and oftentimes she didn't have a babysitter, so I would sit in classes with her, uh, reading her flashcards and helping her with terms and books. And I began to hear a lot about her work once she became that nurse. But it was a very stressful job. And there was a lot of interaction, sometimes negative, not just with patients, but also with supervisors and administrators. So it really brought back something to me when I started looking into the field. It reminded me a lot of what I remember when I was a child.
Charles, I did a little homework before this interview. I've looked at some of your student ratings. You're a popular guy. Students like you. They like being in your class. That you had told me previously that you've taught hundreds, maybe thousands, who
Thousands.
eventually went into healthcare. How personal does that make this for you? I mean, what does it feel like to see students you've taught go into this industry that is experiencing this workplace violence crisis right now?
It's bittersweet. I mean, it makes me happy that so many people that been able to affect in a general education course are going into such an important field. But it does make me worry a little bit, and I would love to be able to go back and see how many have still stayed in the field after all this time. But it motivates me. This paper, what motivated me was partly from my students, just to see what they're dealing with and what I might be able to do to possibly change that.
Charles, my question for you is when you walk into a hospital or a clinic, um, how do you see it differently, being the sociologist that you are, and especially after having written this white paper?
Honestly, I've always paid attention to the interaction that would go on between the patients, the workers, the administration, the supervisors. Very fascinating to me just to watch what the everyday interactions that took place. I guess I always thought to myself that this is a really difficult job. And these people that work here go through a lot. And sometimes you can see that it's hard for them to always control the emotion simply because of the nature of that job.
Well, Charles, let's get into the paper. A sociologist and a sociologist's lens, that's an important perspective. And you're very upfront in the paper about the fact that you're not a healthcare insider. And you actually frame this as a feature rather than a limitation. Explain to me what you mean by that.
It's the classic outsider looking inside. I think that's always helpful so it doesn't become an echo chamber of what you're trying to figure out. But The other big thing, again, is because I can analyze it as a social institution, which is what we do in sociology. We look at all of these different parts of society as social institutions with their own rules, their own roles that one plays, their own expectations. I have a unique way of looking at it as an outsider, not just as an outsider to the healthcare industry, but an outsider to society itself, in the sense that I can step back and look at how that piece fits in, how it's alike, and how it's different from other organizations in society.
So, Charles, in your paper, you write that when the same problems keep appearing across different settings with different people, they're rarely random. You say that they're structured. Can you unpack that a little bit for someone who runs a hospital or manages a compliance program, for example?
Life is not as random, it's not as spontaneous as we think. So, to give it specifically attention to the paper here, while violence, while issues might appear random, they're not. Most of social life is based on patterns. So, we always look at the context in which the organization exists. We look at the norms, the guidelines, the expectations. We look at the roles that one is expected to play. And we understand that those roles, those statuses that we hold, those expectations that we have, they're not just behavioral, they're also emotional. We're actually trained to feel a certain way depending on the job. Now, obviously, some jobs would have that emotional expectation more than others. But nonetheless, the fact that we see these patterns, the fact that we see how the outside world affects what's going on there as well as the organization, we're able to comment and understand in a better way.
So, in the paper, you reference seminal work by W. Richard Scott. It's his three pillars framework, which, as I understand it, is regulative, normative, and cultural cognitive. Pretend I'm one of your freshman sociology students for a moment. In plain terms, what does that mean? What is Scott telling us?
Scott is showing us, again, what I just said, that there are patterns, and he's recognized a pattern. And he is identifying that pattern. And it falls, like you said, into three different characteristics or three different ways of looking at it. In terms of the way people interact in a healthcare organization, we are going to tolerate things based on three aspects. This first construct is going to be coercion. We're going to be forced into it. And this is one of the biggest problems, because if we try to simply change the rules of an organization, that's not necessarily going to work, because that's straight what you tell a child. It's basically a child asking, why do I have to do this? And the parent saying, because you have to, because I said so. That's only going to take you so far. The next thing is the building of the behavior into the norms, the average everyday norms, not just the social norms that we follow, stopping at a red light, going at a green light, but also the norms of the profession, the expectations of that profession. How are you supposed to act? What are you supposed to do? And the last, of course, is going to be the general morals or ethics of a society, the feeling that this is what we do. We always do this. We learn it. We're socialized with it. These three together, each step of the way, guide us. And so if behavior is going to change, if institutional culture is going to change, you've got to filter it through those three things and know which ones are going to have a more lasting impact than others.
So I'm looking for a practical takeaway from this. And it seems to me that it might be, as a healthcare organization, if your only tool is a policy, you're going to lose. Is that a fair read of that?
Absolutely. That would be the first, the coercive aspect of it. You can make as many policies as you'd like, but unless they're followed, unless people think they're making a difference with that policy, then they're either going to be ignored or they're going to be taught to the next generation of healthcare workers that this isn't necessary, this doesn't work. You're going to create a kind of pessimism or cynicism about these new kind of policies. They've got to be shown that they're actually going to do something, and that people are going to listen to the feedback on these policies as well.
Charles, one of the things I like about your white paper is you bring in a lot of seminal work by key names in the world of sociology. One of those names is Arlie Huckschild. She talks about the concept of emotional labor. Now, for someone who's never heard that term or doesn't know exactly what that means, those two words together, why does it matter here in a healthcare setting?
I think it matters in two big ways. The first, of course, is that some jobs require more emotional labor than others, more emotional investment in what it is you're doing. Now, I have nothing wrong to say with fast food workers, but obviously they're not going to put as much emotional investment into what it is they're doing than, say, a nurse. Although sometimes the emotional investment becomes the central expectation of that particular job, the central expectation of what the entire organization is all about. And so we have to look much deeper at what kind of effect this is having on the individual and perhaps what kind of unrealistic expectations we are creating when we expect these workers to behave in a certain way. I want to add a second aspect to this, is something that Ms. Hochschild did as well, is that because there is the secondary expectation of women, forget being a nurse right now or any healthcare worker, but women in general to be more emotional. There is an expectation that they are the ones that are supposed to be putting in more emotional labor in relationships. This almost adds a double-barreled kind of expectation. And since we know that many people in the healthcare field are women, that's going to add to it because now it's going to bring in both the professional as well as the personal in terms of expectations of what they are meant to do. And it can take a toll. It's just a recognition these expectations exist and they have to be addressed.
Charles, I think your paper also makes an uncomfortable observation, and that is when composure becomes the measure of professionalism. The worker who says, this is not acceptable, well, they can actually end up looking like the problem. Can you address that in a little bit more depth?
It's a misunderstanding of the patient or the patient's family of of who that healthcare worker is and what they are supposed to be doing. And so we could make the argument that these are completely unfair expectations in many cases, but and can have a detrimental effect not just on the worker's psychology, their psychological well-being, but on the interaction that's taking place within that situation. And so it's because the patient doesn't understand. They've got their own personal expectations of what is supposed to be going on here. And the healthcare worker, or they know they're expected to be they're expected to portray themselves a certain way, but they are human beings, and that's not always going to come out that way. And so essentially you've got this dynamic of the worker caught between a rock and a hard place. So they're going to be looked at as either angry or mean or less competent or simply not good at their job. So the patient is expecting for some level of emotion or empathy that's put into to this interaction. And that nurse might be working a 12 or 14-hour shift and they don't have it in them. I think it's that they're looking for more empathy and they're not getting it. They will misunderstand what they're seeing. Instead of empathizing with the worker, they're going to immediately take it as something personal. And that will then reflect low on the worker themselves.
Charles, your paper addresses the underreporting of incidents. It can be by a significant factor. Some studies have indicated that up to 50% of incidents go unreported. Your paper identifies that not as a worker failure, but as organizational feedback. Now, can you explain that distinction?
When I was first researching this reminded me so much of law enforcement. In law enforcement, there's a lot of underreporting as well. And a lot of times it could be for the same reasons. If the person that's doing the reporting is taking the time and the effort to do all this, and it is either ignored as if it was unnecessary to even do that, or it's ignored in terms of suggestions or things that would make the organization more efficient, then they're just not going to do it. They're just going to reject it or do as minimal as possible. And that obviously hurts everybody involved. It hurts the organization. It hurts the victim. It hurts the worker. Another reason might very well be that they want to make the organization look better than it is, and so they will only put information that is not completely accurate, just to avoid any kind of negative consequences. So this is not a reflection on the worker, it's a reflection on the culture of the organization. And like I said, healthcare is not the only organization where this takes place.
You also write, somewhat related to this, that the most revealing moment is after something goes wrong. So, what are leaders actually communicating in that moment, whether they intend to or not?
Well, it's a reaction. It's reactionary. It's not proactive, it's reactive. And so rather than doing something that is going to prevent that something wrong from happening again, they are simply going to take care of it after the fact. So it's the classic either dealing with it beforehand, recognizing it and dealing with it, or just waiting till it happens. And the problem is if you wait till after it happens, it could be a lot more negative for the organization or for the people involved.
Charles, I'm going to use some healthcare lingo now. All right. As you look at workplace violence in healthcare, is this an acute condition or a chronic condition?
I agree that while it may appear chronic, this is completely curable, and this is something that can, in fact, can be managed and perhaps even completely cured.
That would suggest that you think that there's hope for the system. That's a good thing, which leads me to another question. I want you to think about somebody who might be watching our interview. It might be a security director at a healthcare organization or a compliance officer or somebody in the C-suite. What are one or two things that you want them to see differently, that you hope that your paper will have had an impact upon?
This is a solvable issue. It's not lost. It's not something you have to keep throwing money at. It is something that can be changed. It's going to be changed on many levels, organizational, in terms of workers, but it is something that can be done. You're in a difficult field. You're dealing with emotion. You're dealing with healthcare. You're dealing with pain. And so it is more difficult than other fields. There's a lot of complexity there, but anything can change. This is a system that's created by human beings, so it's a system that can be changed by human beings as well. Don't despair.
That's good. I'm glad to hear you say that, but I want to push back on that just a little bit. All right. Are you an outlier? In other words, if I were to pull together a dozen sociology professors, your peers from around the country, and if they were to have done the same research that you've done, and I were having this conversation now, do you think that most of them would tell me that this is solvable?
I would hope so. I mean, that's part of what sociology is. It's to come up with solutions, it's to explain and show people that there are other ways of doing things, or at least if it's a specific problem we're trying to address, a sociologist is going to try to find that solution. Now, there's different fields of sociology, and there's all different kinds of sociologists. Uh, I don't think I'm an outlier in anything I've said. We're talking about an entire system here. I don't think it would be out of line for other sociologists to suggest to you that any system is changeable. There is no such thing as a system that can never change. We're a society made up of people, ideas, norms, and values, so they can be changed by those very same people. Is it a little more optimistic? I've never been accused of being optimistic, but I think it's just a basic tenet of sociology.
So, back to the title of your paper, The Storm is Already Here. And you told me that was a very deliberate choice. Um, why? What does that mean? And what do you want people to feel as they see that title and as they read your paper?
I think that people tend to put things off. They make them farther away than they are so they don't have to deal with them, keep kicking the can down the road, if you will. So maybe kind of letting people know that this isn't something that is slowly moving towards us, that we can see off in the distance and we've got plenty of time to deal with it. This is something that people are dealing with right now every single day. It's been going on for quite some time. So I'm hoping that people see the severity of this situation and realize that the time to act is now.
Well, we've been visiting with Professor Charles Levy, a sociologist with lots of experience teaching students really at all levels, from high school all the way up to graduate students. We've talked about his paper. The storm is already here. There's some information following this video on how you can get a copy of that paper. This is brought to you by Optics for Healthcare. And Charles, again, I want to thank you for sharing with us some information about your paper and spending some time with us here today.
You're welcome. Thank you.